Hello everyone, thank you for the opportunity to present the technique of en bloc enucleation of the prostate, a procedure for BPH treatment at Binh General Hospital. We have applied, developed, and refined this technique in 2021 using 3 different energy sources. There have been several reports to be published and reported in both domestic and international conferences. Over the past 2 decades, surgical treatment options for BPH have seen significant advancements, with a clear trend towards transurethral endoscopic interventions, regardless of prostate size. Author Lipschitz and colleagues reported on the current state of BPH treatment and used the ARIMA model to predict that laser enucleation is gradually becoming more popular and expect to surpass TURP in the coming years. We would like to summarize the enucleation technique with a simulation video. Our technique is based on the basic movements of rocking and rotating to create physical force to sweep and strip the adenoma away from the surgical capsule. These steps include opening the mucosa and identifying the surgical capsule, followed by the enucleation of the 2 lateral lobes and parts of the middle lobe, starting from the previously identified surgical capsule. The third step is to release the apex of the adenoma by cutting the mucosal bridge at the 12 o'clock position and enter the bladder at this position. Finally, the enucleated adenoma is pushed into the bladder and gets morcellated. To perform the movements in this technique, we use the beak of the resector scope sheet as a blunt tool to perform the rotating and sweeping to remove the adenoma away from the surgical capsule, while energies are used mostly for hemostasis and cutting connecting tissue. And the surgical capsule is the key to perfecting our technique. The steps in our technique are presented in more detail below. Firstly, we use energy to open the mucosa on the left lobe, right in the middle of the groove between the verumentanum and the left lobe. After opening the mucosa, we use the tip of the scope sheet to apply a shaking force to find the surgical capsule separated from the adenoma at this position. Secondly, we begin enucleation starting from the identified surgical capsule on the left lobe in a counterclockwise direction towards the 12 o'clock position. Continuous semicular movements are made in this manner, gradually advancing towards the bladder neck until no further progress can be made. The surgical capsule or surgical plane is a crucial landmark for perfecting our technique. The most significant document in refining our technique was written by Arthur Page in 1980 when he studied the prostate anatomy on cadavers. Normally, the prostate capsule is a thin fibrous layer that envelopes and is inseparable from the adenoma. When BPH occurs, the glandular nodules form in the transitional zone, roll and push the remaining anatomical regions outward, compressing them into a thin layer surrounding the hyperplastic nodules known as the surgical capsule. Next, we retract the scope to the level of the verumentanum, connecting a mucosal incision from the previously plane across the verumentanum to the right lobe. We continue using rocking, rotating, and sweeping movements to develop and expand the surgical capsule to the median lobe in front of the verumentanum and the right lobe. Similar movements are performed in a clockwise direction to enucleate the adenoma in the right lobe towards the 12 o'clock position and in a direction towards the bladder neck. After enucleating the 2 lateral lobes, part of the median lobe can be enucleated from the identified surgical plane. Step 3 is handling the mucosal bridge connecting the adenoma to the membranous urethra up to the bladder neck. We retract the scope to the level of the verumentanum, directing it towards the 12 o'clock position. At this point, the adenoma is connected to the membranous urethra by a mucosal bridge. We proceed to cut this mucosal bridge, being careful to avoid injury to the sphincter's muscles. The cutting process is also performed gradually towards the bladder neck. After cutting the mucosal bridge connecting the adenoma to the urethra, we continue to separate the apex of the prostate from the anterior fibromuscular stoma. When only a thin membrane with longitudinal fibers remains in front, we proceed to cut and enter the bladder at that position, now at the 12 o'clock position. After releasing the apex of the adenoma from the bladder neck, we follow the circular muscle fibers of the bladder neck, enucleating the two lateral lobes of the prostate into semicircular movements downwards to the 6 o'clock position. The median lobe of the prostate may be deeply embedded or protrude into the bladder neck, so if enucleation is performed directly from the verumentanum to the bladder neck, it may cause injury to important structures at the posterior bladder wall, such as the seminal vesicles and urethral orifices. Therefore, we only enucleate part of the median lobe from the initial plane in front of the verumentanum, and after reaching the 6 o'clock position at the bladder neck from the previous semicircular movements, the remaining of median lobe is enucleated back towards the verumentanum, thereby preserving the bladder neck and the aforementioned structures. Step 4. We push the enucleated adenoma into the bladder and do the morcellation. Before that, we carefully achieve hemostasis on the surgical plane that had just been enucleated. Attention should be paid to common bleeding points around the verumentanum and the bladder neck. With a good hemostasis, a clear surgery field will facilitate the morcellation process. After achieving hemostasis, we proceed to morcellate the adenoma inside the bladder. During morcellation, we always keep the bladder distended to avoid bladder injury. In summary, we have performed this en bloc transurethral enucleation technique on 74 BPH patients at the Department of Urology, Binh General Hospital. Among them, 35 cases were performed with bipolar, 30 cases with holmium laser, and 9 cases with thulium laser. The results have shown feasibility, safety, and effectiveness with short surgery times, short hospital stays, low complication rate, and good symptom improvement post-surgery.